You are listening to Walking Home from the ICU. We will be exploring how to save and preserve lives in the ICU. All opinions and views shared are unaffiliated with any organization. Now that we've heard about the months it took for a patient like Jim to be able to walk again, let's look at what it took to get there. We're going to explore prevention and treatment of severe deconditioning. Susi Rimkus is a seasoned nurse practitioner in critical care. As a post-acute care expert, she now gives us insight into barriers in maintaining and restoring function beyond the hospital. She's also going to give us guidance on how to change priorities to eliminate LTAC or rehabilitation from patients' journeys altogether. Susi, thank you so much for joining us. It's so exciting and such an honor to talk to you. Can you give us a timeline of your career?
Sure. Thank you very much for having me. I got my bachelor's degree in nursing, and then I went to pursue my master's of science in nursing as a nurse practitioner, and then I did my doctor of nursing practice. So over almost 3 decades, over 20 years, I work in critical care medicine.
Wow.
But now I'm working post-acute care medicine at respiratory units in skilled nursing facilities for respiratory failure with tracheostomy and or mechanical ventilator patients.
And why are those patients coming to you? Like, why do they have tracheostomies? What's caused their respiratory failure?
Well, the main reason why they come to me is because of the inability that they have to win from mechanical ventilation, from hospitalization, from LTAC, and now they are at the SNF in a respiratory unit. And that is coupled with severe deconditioning and delirium.
So these are patients that have had a critical illness. They've been in the ICU, correct?
Yes.
They were on ventilators.
Yes.
Intubated. And then you're saying that the severe deconditioning, so probably from sedation and mobility.
Exactly.
They then become ventilator dependent. And so do they still have active pneumonia going on? Or so any of those acute or critical processes going on causing respiratory failure?
Most of them come free of infection, but very, severe deconditioned, is still over sedated, psychotic, in delirium, and unable to breathe on their own. Very, very weak patient, but free of infection. Some does come with infection, believe it or not.
Mm-hmm.
Yep.
Wow. I know I think of, at least in the ICU, when I think of respiratory failure, I start thinking of differentials like, pulmonary hemorrhage, infection, all the different things that can happen. But this respiratory failure, this failure to be able to breathe is mostly at that point from deconditioning. These are patients that cannot hold their head up. They can't take their own breaths because they haven't usually how long has it been since they've been moved?
Well, it could be from 2 weeks because I don't know if I told you, but 40% of our patients come direct from the ICU to us. About 49 come from LTAC %, and 1% from other skilled nursing facilities or even physician's office. So when they come to us, the medical diagnosis, yes, they are sick and they are severe deconditioned because they got pneumonia, but as being critical care medicine before and being post-acute care, I can tell you right now, the patient doesn't have pneumonia, but the patient is severe deconditioned and sedated, encephalopathic.
So they're coming to you and they still are under the influence of sedation, still have delirium?
Exactly.
So they're too delirious to even coordinate their body, and now they don't have the strength to, and that's caused them to be dependent on the ventilator.
Yes, they are very weak. They don't have no strength. They can't breathe on their own.
And so what is that like for you? I know, having done critical care for almost 30 years, you had to have seen, because I know that you worked with Polly Bailey, so you've seen it both ways. You've seen the path of sedation and immobility, and you've seen what it's like to have patients in the ICU awake and moving. So now that you're doing LTAC and SNF, you're on the other side of it. What is it like for you to know that maybe this could have been prevented?
Oh, definitely. I would say 75% of the patients that I get that is in respiratory failure, they probably could be prevented. When I see the work that we have done in an ICU and the work that I have in a skilled nursing facility right now, it just showed to me that even though we have been doing this since 2006, the people around us, like the medical society, the nurse practitioner, the staff, the nurses, the systems have not changed. Despite of the literature, despite of the benefits they offer for the patient, we're still in the old days. Oh, let's take care of the acute illness, sedate them, they are too sick to walk. How many research we have proving, even if the patient is start an acute illness and have, physically he is strong, he has better outcomes than the patient that is weak and is start an acute illness. Yeah, so for me, it's frustrated to see that nothing has changed. Independent of all the literature, all the studies, or the so much good we did in our ICU, it seems like that the medical community doesn't adhere to that or doesn't change their practice.
Despite all the big pushes and talk that have been made about.
And the outcomes.
Yeah.
Patients going home, improving quality of life, able to breathe, decannulate, no ventilator. Instead of going to a SNF, why not go home?
Yet we're still stuck.
We're still stuck on that.
We're still leaving people
with our
bed.
old practices.
Yeah.
Yeah.
And so now you've transitioned to this role of, dare I say, cleaning up the messes that we've made.
Exactly.
And you already had this personal culture of being awake and mobile for your patients.
Yes.
So when you started in an LTAC.
Yes, I started in an LTAC.
What was that like, trying to bring that focus into an LTAC?
Was hard as was to bring to our ICU. So I worked in 3 different ICUs in the same system. So the first ICU was not interested at all on this awake, alert, mobile culture, where we would light it up the sedation, make the patients awake and alert, work on their physical strength so we could decannulate them and prevent some short-term and long-term detrimental outcomes from these patients, due to immobility and over-sedation, which most of the time is completely unnecessary or over-treated with sedation. And it is the same argument I have at that time. And then I went to another ICU, and we have new nurses. And believe it or not, they understand and engage on that culture, and it did work with them. Then I went to another ICU that was all the nurses, but with the group of nurse practitioners and our leader, a physician, they all changed their practice to that way. So now I'm starting again. But as you can see by my example, one ICU didn't work at all. They were not welcoming the outcomes. Their mind frame was, they are too sick. I'm not here to answer call lights. I'm here to take care of the wellness and send them back to who is going to rehabilitate them. Some people still feel this way. The second one, because you got new nurses, a new unit, the new nurses were anxious to receive education, teaching, so they went with. And the third group of this ICU, they are older nurses, but they welcome the change as they start witnessing the ability of the patient to go home. To their beloved ones. They start taking ownership for that. So here I am starting a new culture, and I was trying to figure out, is this group going to be the ones that didn't want, the ones that took, or the ones that, even though have tons of experience in the past, decide to change their practice? And the LTAC that I work on, they didn't want to. They did not want to. It was so much complaints from the physicians and the staff because they didn't have a resource. That is exactly the same thing I hear when I go to a Society of Critical Care Medicine conferences that we go. Oh, we can't do that. You know, physicians and nurses come to the microphone. Oh, we don't have the resource. Oh, we don't have the money. Oh, we don't have the time. Oh, we don't have the staff. It is the same thing. And so I just have to embark on that again. But, you know, I took for that. The LTAC was just one, did not take in. SNFs, some SNFs decide to take it in, but then because of so much complaints from family, patients, and the team, they decide to abort that culture. But many SNFs embrace it. And a SNF is a good place to do this culture too, because the nurses, they are not valued most of the time. They don't have, I don't know if you know, but a physician by Medicare, Medicaid should see the patients once a month. I go there at least twice a week. So the nurses were craving to have somebody to teach, to value them, to help them help their patients. So they really embrace. As you can see, I have vent units that I have 25 patients.
Okay, I got to clarify.
Oh,
so,
sorry.
No, you're good. So an LTAC, and we know that those can do ventilators.
Yes.
And those, in my mind, I was thinking LTAC was more of rehabilitation. I mean, especially when they're coming out of the ICU,
Not
that
really.
they're there to clean up the mess of the ICU, to rehabilitate them, get them strong, mobile, and decannulated. So you're talking about ventilators on a SNF? How did that happen?
Yes, so what we did, we created and developed respiratory units in a SNF where I could take care of the straight mechanical ventilator patients, severe debilitated, encephalopathic, in delirium, psychosis. So the same thing I would do in an LTAC, I do in a SNF.
And yet the nurses were more willing to do it.
Yes.
Than they were in the LTAC.
Yes.
And tell me about these patients that are coming to the SNFs. I mean, that's not the first place. I don't think an ICU would think to send their trach ventilator-dependent patient to a SNF. So they must have been in an LTAC first.
Sometimes we have patients that comes from the straight ICU. For example, I have a hospital in town that will call me and tell me, Susie, I have this kind of patient. Do you think you can take care of the patient? I said, yeah, I think so. It's just like post-acute care medicine in a SNF.
Wow.
And I did that because the LTAC did not welcome my culture. So I turned a SNF into an LTAC.
That's amazing. So I'm just a little astounded that the LTAC was not interested in waking patients up and mobilizing them.
Yeah, they say they are, but they go too slow for our culture. Our culture dictates that the patient must do as much as they can do at any given time. We don't do progressively. Oh, today we are going to stand. In the afternoon or tomorrow we are going, no, today we are going to dangle. In the afternoon or tomorrow we are going to stand. The next day session, we are going to do one step. The next action, we're going to do 3-step. The next session, we are going to put you sitting up. It takes too long.
Mm-hmm.
And if the patient say, oh, I'm in pain and this, they stop. You can't do that.
Uh-huh.
Is the pain? Let me know. I'll take care of the pain an hour before you come and do therapy. But you have to, it's the patient, the body that needs to tell you when they cannot do it.
So this is all personalized, individualized
Yes.
for where the patient's at, considering what their baseline was, how long they've been immobile.
Therapist goes by their baseline activity, but I always remind them and educate them that we are there to do the extra mile. The patients need to do as much they can do at any given time, and that means this. And I have examples that patients had not walked for 8 years. 8 years. In a sniff, a trach patient. He just started walking last year under our care. Yeah, it's not because we are magical. It's because we do it. Has a difference between, we do that. Most LTAC, sniffs, and hospitals, they will tell you, oh, yeah, we walk them, we do the best. They don't. When they come to me, I can read in terms of activity what they have done for the patient. Yeah.
And then how do you get that focus? I mean, these are patients that sometimes have been kind of written off by other therapists, other facilities. They're just going to be stuck on the vent. They got critically ill and that's it for them. They are stuck on the vent. So what is it about your perspective or your approach that actually gets these people decannulated?
So what I do, like I told you, we meet with the family, administration, the whole IDT team, and I tell them in this meeting, this is the end of bucket. Nobody thinks that your beloved one can go home. They think they are here to be here. That's their house. We don't want that. We want him to go home. And what we need to do is a lot of hard work. I do engage a family because in a SNF, in any SNF, the monies for therapy is very low and it is limited. I do have one SNF that has their private therapist. Even patients that doesn't have the money, they provide that. It's interesting, but this facility is owned by a nurse. Nurses knows what that. Most of my patients are already done by the system. It's nothing can be done with them, but we prove them wrong because we have a patient that wants to go home. We have a family that want to support them to go home. And we have a whole team that is there to treat and give the best in a timely manner. We cannot wait 6 months or a year. He's going to be even more the condition. It has to be right now. And that's why we do it. That is the only difference. And it's interesting that the people around, the family, the patient, administration, they all have an ownership. Now these meetings are conducted without me present because they took it.
They get it.
Yeah, they get it. They engage. They witness. It's not me telling them. The beginning is me telling them and walking with them. But I'm a kind of a different provider too. I'm 5 days a week on call. I see each facility 2 days a week. I engage in educating nurses, RTs, CNAs, speech therapists, any kind of therapist at the bedside. They have a question, I'm there. They need the help, they are not controlling the patient. We work in solutions. So we work very close together. So the team that I have is phenomenal. In fact, to be honest, they really don't need me there anymore. They can just do by themselves.
Because they know how to.
Yeah. And they took ownership. They have seen the goodness they bring. and they feel excited about, just like me. I'm very excited.
Susie, I'm such a believer of that. When you go to these conferences and they say, well, we can't get our nurses to do that.
I know.
But I just truly believe that if nurses knew the why, if they knew, at least in the ICU, that they could prevent suffering, prevent damage, give patients their lives back, they would get them up.
They need to try.
Mm-hmm.
They need to be open to try. Most of the people that I have problems is they don't believe, but they are not open to try. If you are open to try, you will know and see for yourself.
Yeah. And it just blows my mind. These are people that were kind of written off. Like they're going to be stuck to a machine the rest of their lives. No use. And also the fact that mobility, waking up and moving and working hard, reversed these irreversible conditions.
Yes.
Reaffirms to me.
And prevents complications too. That's what you have to say. The pneumonia. Why are you psychotic and everything? It's the drugs, but it's also the environment. If you stay in a room just looking at the walls, wouldn't you be psychotic too? I think so.
Yeah. And looking at the big picture.
Yes.
And if we could just do that to begin with when they first get sick.
Oh, that would be a blessing. We wouldn't need sniffs or anything. I don't know if Polly mentioned to you. We did a study in one of the ICUs. And what year was that? On early aggressive, not progressive, mobility for respiratory failure patients. And it revealed that the patients can discharge from ICU to home 96% of the time if they walk 200 feet or more twice a day during their ICU stay.
The main difference seems to come down to the culture,
the
focus, and the approach to being awake and walking.
Yes, this is all about the culture. And that's what I mean. It's not me teaching them. It's a culture change, and they have to be open to that.
And so what does that mean meant for the decannulation rates for your patients, having this approach even months, almost a year after being left in bed to waste?
I know. So this is a consequence. So in a country, the rate of decannulation for a SNF patient, but you have to think also, they probably, and I'm sure, I would say it's 13.4% the decannulation. On a SNF in general, we have 50 to 60%. Our readmission rate is 1 to 2%.
Wow.
Okay. Now, the length of stay is harder. It's 120 days. Because as you know, these patients come very debilitated. I have patient that has been not out of bed for 6 months.
Uh-huh.
Yeah, tell me about that. So it takes more days, but we do it.
Wow. I have to clarify. So about 13.4% on average nationally are decannulated, meaning they're
in
able,
a SNF.
meaning decannulated, meaning they're able to get off of the ventilator and breathe on their own and have that darn hole in their throat closed up.
Yes.
So 13.4% on average.
Mm-hmm.
Yet your average, even with patients that haven't walked for 6 months and even longer, 50 to 60%.
50 to 60%.
Susie, that is
I need to do a study. In fact, not a study. I have all the data, but I need to find someone I can give the data just to write the paper for me.
Mm-hmm.
Yeah. It's beautiful what we are doing. It's beautiful. I'm very happy.
So this process works.
Oh, definitely. But that's what I mean. I took a process in an ICU, took to an LTAC, and I took to a SNF in a specialized respiratory unit. And it works. Now, the LTAC, I don't have much experience because I only went to one. Mm-hmm. So I cannot answer about the others. But I just want you to know that a lot of people say, but they don't do it. If you go to my facilities, you're going to see, let me tell the facilities that I used to work and work now. Before they used to have, I remember one facility, the patients are all in bed. You can come any time of the day. They are 24/7. So I started waking them up. We didn't have a dining room because the ventrate patients don't go to the dining room. They can't eat.
Right.
Oh
So
my goodness, we
isolated.
changed that. Today, we have a dining room. Today, not only today, but a couple of years, I would see the patients coming to the foyer. Can you imagine the happiness that I had? The nurses were so happy. They would say, Dr. Susi, look, all the patients are here to say hi to you. When I come
up
in,
out of their beds.
up out of their bed. Even those paraplegics, quadriplegic, those anoxic brain injuries, they do as most as they can do. Even if they can't walk, they are up and about in creativity, in rooms, activities, in outing, going to the dining room, have a speech. I also do this. If the patient cannot, some patients, they don't have a family support to take them home, even when you decannulate. I have a little Indian grandma in the family told me, if you decannulate her, I'll take her home. It took a little bit, but we decannulate, and they never took her home. She went to a long-term facility. So we do have those cases that sometimes you decannulate and they don't go home. But the possibility was there, but it has to do with the family. That's why now I involve the family on that process. But it's, improve quality of life, even if it is to stay in a wheelchair. At least you're in a wheelchair, strong, moving, in a power chair that you can move and do things. And then for those that cannot have, for example, decannulation, sometimes it happens, anoxic brain injuries or traumatic brain injuries. What we do, then I involve a speech therapist to see if they can eat with the trach. It's safer than being intubated. So we do that for them. And then they can live the life that they want, in a wheelchair, in a power chair, eating and being happy. Awake and alert, going to religious service, family reunion, to movies. Tell me about.
They're living lives.
Yes, exactly. Got it? That's what we do. First, we want a curer to go home. Second, if we cannot cure it, do the best that they can in awake, alert, and mobile so they can go home. And those few that cannot go home, we maximize activity and quality of life to stay there or not.
That's amazing.
Yeah, families are really happy. The satisfaction increase. At the beginning is low. Family complains, oh, my beloved one is anxious. And I always say, oh, we need to get him up. And they say, getting him up, but just give him medication to me, because that's what the hospital does.
Just sedate him.
Yeah. So my nurses are outstanding. At the beginning, I used to receive a call in the middle of the night. Oh, the patient is agitated. Can I give something for him? And I said, yes. Get him up, put him in a chair, and put him by you. Oh, okay. And then I had one patient that me and the administrator of that unit, everybody said they could not walk the patient. I grabbed the patient one side, him and another, and we walked the patient up and down, up and down. By the end, the patient was doing the walk with us. Then he was agitated. So they want to send him to the hospital because Sniffy has different rules in hospital. They didn't want to get antipsychotics or anything. So we just make the walk, put him in bed. He slept so good with no medication. I'll tell you. Yeah.
And if we only had that perspective within the hospital.
Oh, tell me.
We could put you out of business, right?
Oh, completely. And I'm glad I go completely for that. When we are in an era that we talk about cutting costs, better outcomes, I'm not talking about alive or dead, because I don't think that is what we want for life. Oh, I want to be alive, but comatose. No, we need to talk about the outcome. What improved quality of life? That must be your outcome also. So I don't know why people don't do it. It could be the pressure from the people that is not used to do that. But yeah, definitely would be a huge gain for the hospitals. No SNFs, no LTACs. Maybe you need some rehab depending the situation of the patient. We'll get rid of that. The patients will back home. Families or patient go back to work. If the patient cannot go back to work to help society, at least the family members care, because when a beloved one is sick, what does family say? They miss work, they take leave of absence because they have a family. Everything would be much better.
We just did it from day one, the moment they rolled into the hospital.
This is called priority. It's not about resource. It's not about money. It's about priority. Nurses, physicians, staff needs to know, where are the priorities in this patient? And you have to see, is awake, alert, mobile. Infections is going to decrease, the cubitus ulcer is going to decrease, what else? Psychosis will decrease, delirium is going to decrease.
Cognitive deficit.
Yes, and well-being and happiness to be able to go back where they belong. They don't belong at the SNF. They don't belong to an LTAC. They don't belong to the hospital.
The right priorities, establishing a culture and practice within a multidisciplinary team to give patients their lives back. I hope that you are out of business in 10 years.
Amen.
If you want to join in on the conversation, leave a voicemail at 801-784-0477.